Hello and welcome back to the Dr. Vincent Buscemi Show. I'm your host, General Dentist, Dr. Vincent Buscemi. I have to add that in because I'm not a specialist. I'm not a physician. I'm not a scientist. I have an undergrad degree in biology, which is worthless. And I have a DDS, and I'm a general dentist. And after dental school, I received no formal training. Everything else has been through continuing education and self-research. I am only a general dentist, not a physician, not a scientist, just a man, not a boy. Okay, so the reason why I say that is because I'm going to review an article that talks about orthodontics. I'm not an orthodontist. Do I do orthodontics? Yes. I do clear aligner therapy, which a common brand is Invisalign. And I'm not pro or anti Invisalign. And I'm also starting to get into what Felix Lee Owl calls biomimetic oral appliances, or David Singh, his mentor, who's a researcher at Stanford, calls it epigenetic oral appliances, or what a regular guy like me calls expanders. Getting into it, but I'm not an orthodontist. I need to say that 1,000 times, so when an orthodontist sues me and I'm in court in front of the board, no one's going to come back and say he was portraying himself as a specialist. Because as I said in a TikTok video that kind of people were commenting on is, I'm not a specialist, I'm just a special guy. Okay, let's start with the story. I graduated dental school in 2014. My first job was with my dentist when I was a kid. Not a bad guy. We just had different philosophies on how to be people. Anyway, young patient comes in. I don't know, he's probably 8 or 9, and it's a referral from a orthodontist to the practice. And it said, please extract 4 premolars, and gave me the numbers because all teeth are numbered, for future orthodontics. Kid sat down with his dad. Dad could give 2 shits one way or another what we were doing. And I read this referral, and I just said, hold on, let me go in the back. And I walked to the back, and again, my boss is a good guy. We were just raised in completely different time periods. And I said, listen, I don't think it's a good idea to extract 4 healthy teeth and then have this guy do orthodontics, this kid do orthodontics. It's not malpractice to do this. It's not against the law. I just don't think it's good because I've been kind of reading some things that it may cause problems down the road. TMJ problems, joint problems, possible sleep apnea. But at that point in my life, I was 27. I've just graduated dental school. And I didn't know anything about dentistry, about life, anything. And my boss says, listen, I'm super busy. You pull them or I'll pull them. But I don't want this patient to leave. So I need it to be done. But I'm too busy to do this. So I would like you to do this. He didn't force me to do it. I would like you to do it. I walked back in the room and I asked the dad, are you sure you want me to do this? And the dad said, pull these kids' teeth out. We got stuff to do. So this is the only time in my 11 years of being a dentist, 4 years in school, 11 years in private practice, so 15 years of working on patients. This is the only time I've ever have done extraction orthodontics, where I pulled 4 healthy premolars in a kid. And then he went back to the orthodontist and they pulled all his teeth back. And I don't know what happened. Hopefully this kid, he's probably in his 20s now. Hopefully he doesn't have sleep apnea. Hopefully he doesn't have TMJ problems, TMD, temporomandibular disorder. Hopefully not. It's one of the worst things I've done as a dentist. And it's completely within the range of standard of care, which is crazy. One of the worst things I feel like I've ever done to a patient is completely in the standard of care. So a lot of orthodontists will say, I did nothing wrong. Because they cite this, many articles, but they cite this article where it says, evidence supports no relationship between obstructive sleep apnea and premolar extraction. a electronic health records review. This was done in 2015. However, if you've ever read the book Jaws by Dr. Sandra Kahn, who's an orthodontist, or if you've ever read Nutrition and Physical Degeneration by Weston A. Price, or if you've ever looked at any archaeological, reviews of human skulls and mandibles, our jaw is shrinking. If you read anything by Felix Liao, if you even just go online, look at some dentists who are kind of fringe, or at least on the outskirts of dentistry, our jaws are shrinking. That's not fringe. But what's considered fringe by mainstream dentistry is that our shrinking jaws are causing a problem. By extracting some kids' premolars and pushing everything back with orthodontics, you are artificially shrinking this person's jaw. Now, we'll have to do another podcast why our jaws are shrinking and why that's a problem. The main thing is it's epigenetics, not genetics, but it's environmental. Our jaws are shrinking because we're eating softer foods. We don't breastfeed as long. Our lifestyles have changed. We're breathing through our mouth. So there's things causing our jaws to shrink. One thing is actual dentistry is causing it, which is this method of treatment, which is premolar extraction. So an orthodontist actually sent this article to a friend of mine who's a general dentist, who asked him to do the same thing that the orthodontist asked me 11 years ago, pull his teeth through the orthodontics. My buddy, now he's about 11 years out, maybe 12 years like I am, wasn't keen to this type of procedure. So I want to go through this article and kind of show you the weakness of the article and maybe open up your mind that extracting premolars and doing orthodontics is not the best thing. Let's just remove our scientific hat for a second and just put on our logical thinking hat. Whether you believe in God or you believe in evolution, humans used to have all 32 teeth in their jaw with a wide open jaw, and they could chew on them. There used to be no need for removal of wisdom teeth, and there used to be no need of removal of premolar teeth to get straight teeth. And there's still people today in different parts of the world that have this. All 32 teeth, no need for orthodontics, no need for removal of teeth. If our bodies were designed that way, would you think there are complications or negative consequences to not having a wide, broad jaw with all 32 teeth? Would you think that maybe it's not healthy for humans for the need to pull teeth? Maybe the need to pull teeth is a symptom of something else going on, which is a shrinking jaw. So maybe it's not the right thing. There's a concept in, in engineering, I'm sure some parts of nature, function follows form. So the form of something leads to the function of something. So if your jaw is smaller and malformed, it's probably functioning less. But if you look at a more broad view, if your jaw is not well formed, maybe the function of the body is not properly aligned, not properly running. And if you read 6 Foot Tiger, 3 Foot Cage by Felix Liao, he runs through all of that. So let's look at this. A controversy exists concerning the relationship between obstructive sleep apnea and the anatomical position of anterior teeth. Specifically, there has been speculation that extraction orthodontics, which I've done once in my career, and retraction of anterior teeth contributes to obstructive sleep apnea by crowding the tongue and decreasing the airway. OSA, obstructive sleep apnea. This retrospective study utilizes medical records to examine the association between missing premolars and OSA. Already a lot of problems here. Retrospective studies are kind of middle ground for valid, reliable scientific research. Randomized clinical controlled trials, the gold standard. Your brother-in-law's opinion because he read something on Reddit, the bottom. Some random general dentist podcast who wears orange glasses and records it Saturday morning before his kid gets up, pretty close to the bottom. But retrospective studies are not great, reliable evidence. So every time an orthodontist sends someone, another general dentist, a retrospective study, your ears should be perked that maybe there's something else going on here. So here's what they did. Basically, they went back into medical records. So they didn't even see these patients. They went back into medical records and they found patients that were missing all 4 premolars due to extraction and orthodontics. And then they found patients that were diagnosed with OSA. They wanted to see if there was a causation or maybe even correlation between having your premolars removed and obstructive sleep apnea. And they found, of the subjects without missing premolars, 267, 9.56, had received a diagnosis of OSA. Of the subjects with 4 missing premolars, 299, 10.7, had received a diagnosis of OSA. So they conclude, based off just looking at a couple of records, that OSA was not significantly different between the groups. Conclusion: the absence of 4 premolars, 1 from each quadrant, and therefore a presumed indicator of past extraction orthodontic treatment. So I should just say this. They just saw people missing premolars. They don't know if these people actually had orthodontics. So maybe some of these people could have lost premolars, which is actually more in my favor argument, could have lost premolars just from regular wear and tear, breaks off, infection, pulled out, and not pulled back. Is not supported as a significant factor. So we got to stop right here, because here's where this article is not parsing out. Let's say you had 4 premolars pulled and then everything pushed back with orthodontics. That is totally different than if you lose your 4 premolars due to disease or infection, or they cracked out and it wasn't pushed back. So that's kind of a logical fallacy. It's called assumption of homogeneity. Basically, they're lumping individuals together because they're assuming these had extraction orthodontic treatment. But not everybody who loses premolars had extraction orthodontic treatment. So right there, that's like one of the major, there's 5 huge logical fallacies in this article. That's one of them, that they clump those people together. Okay, so individuals with OSA are more likely to die from any cause and more likely to die from cardiovascular disease than those without OSA. Daytime sleepiness caused by OSA can increase the risk of crashing your car and driving off a cliff. So, why? Lack of oxygen. You need oxygen. Number 1 priority, oxygen. Your body will prioritize breathing over everything else. So, if you have OSA and you're not getting oxygen while you sleep, it increases the risk of getting every other disease and dying from every other disease. The article further says, several studies suggest an association between OSA and the size and position of soft and hard structural tissues of the oral facial complex. This includes tongue size, tonsils, adenoids, soft palate, length, thickness, position of the hyoid bone, mandible length, the length of your face, type of bite. So, if there's an association between your facial structure and OSA, but this article says when you pull teeth out and push everything back, there's no association between OSA. There's already a contradiction because there's other studies that show the shape of your face can increase the risk of OSA. But this study is probably implying that pulling your premolars, pushing everything back, doesn't change the shape of your face enough to increase the chance of OSA. So right here, no statistically significant relationship was found between missing premolars and obstructive sleep apnea. This study provides evidence-based findings that will guide practitioners to choose treatment modalities that will best serve their patients. I just don't believe there's no correlation. So right here, other studies suggest that airway volume association with orthodontic surgery or orthodontic treatment may reduce airway space and contribute to OSA. One proposed mechanism is that orthodontic treatment with premolar extractions can decrease the airway space due to retraction of incisors and therefore possibly lead to OSA. That's absolutely true. If you decrease the volume of your mouth, you increase the risk of OSA. There's something called Inspire where they do like surgery and put like an electrical node into your tongue, and it shocks your tongue and moves your tongue forward to help reduce obstructive sleep apnea because there's not enough space. So how could removing of bicuspids or premolars and pushing everything back not increase the risk of sleep apnea? And what do we have here? Some authors found that orthodontic treatment with premolar extraction does not decrease the intraoral space. Okay, this study examines the hypothesis that prevalence of OSA is greater among subjects with a history of missing premolars compared to matched subject controls without missing premolars. And they control for all these other things. I see this all the time. Look up pictures on Google of faces that have premolars extracted and moved back and faces that don't. The faces that don't are more attractive and more symmetrical. The jaw and upper maxilla are more forward. And even if it doesn't cause OSA, because we're such a vain society, it makes you uglier. It makes your face less symmetrical. It makes your face less attractive by doing this. So let's say you don't believe, after all this article, you don't believe me that retraction orthodontics increases the risk of sleep apnea. It makes you uglier. And that should be motivation enough not to do it. So they analyzed data extracted from the claims repository. Right here. Skeletal classifications. Here's a big problem in the study. Skeletal classifications and skeletal measurements were not captured systematically in the EDR, electronic health dental records. So data was not used. So that's a big concern. They found all these patients that were missing premolars, assumed it was from extraction orthodontics, but there was no other measurements taken. And I'm going to pull these other articles up here real quick. There's so many articles that show, and I'll pull these articles on the screen, that you need other measurements that would correlate with sleep apnea and facial changes. So the article that I'm rebutting, saying that there's no concern, but they didn't measure the face. And here's a good article. Obstructive sleep apnea, a correlation of cephalometric and selected demographic variables in obese and non-obese patients. This article finds that the shape of your face, the measurements through a cephalometric scan, does correlate with obstructive sleep apnea. But the article that we are going through says they didn't take that type of scan. So how can you say that extraction orthodontics does not increase the risk of obstructive sleep apnea in this study if this study didn't even use one of the major things needed to see if the structure of your face increases the risk of sleep apnea? Not good. Finally, the way they found if the patient had sleep apnea, they just used diagnostic codes. So if the patient was missing 4 premolars and the patient was diagnosed with sleep apnea, that's all they use to correlate it. And in the beginning of the study, they say that 80 to 90% of patients have undiagnosed obstructive sleep apnea, or 80 to 90% of sleep apnea is undiagnosed. So 80 to 90% of sleep apnea is undiagnosed. But they use these codes for the diagnosis of sleep apnea. So there could be so many other patients that were missing premolars that had undiagnosed sleep apnea that were lumped into the group that extraction orthodontics did not cause sleep apnea. That is another red flag on the study. So let's say you had all 4 premolars pushed back, taken out, orthodontics to push everything back, and you have all the symptoms of sleep apnea and you are harming your body, but you don't achieve the actual diagnosis, but you still have all the health consequences of sleep apnea. This study would lump you in the group of extraction orthodontics, no sleep apnea, which would lead you to believe that extraction orthodontics probably doesn't increase the risk of sleep apnea, which is untrue. So not good. So we move further down this article, and here we go. In the total match sample, 10% had a diagnosis of OSA. An OSA diagnosis was more likely in subjects who were older, that's true, and who had a higher BMI, who were overweight. So basically, the study is saying if you're old and fat, that's a higher risk of obstructive sleep apnea than getting extraction orthodontics. I will say, if you have a facial profile that will increase the risk of obstructive sleep apnea, and you're thin and you're young and you're in really good shape, absolutely you will have a lower chance of getting obstructive sleep apnea than if you're overweight and you're older. So this article just blames old fat people and say they have sleep apnea. It's not the orthodontist's fault. So right here, no significant relationship was found between missing premolars and OSA in the patient population. The limitations of this retrospective study are well recognized. One limitation is sample bias. It is estimated that 80 to 90% of patients with OSA are undiagnosed. So you could have 4 premolars taken out, develop OSA, but is undiagnosed. And then the orthodontic community will say extraction orthodontics does not cause or correlate to obstructive sleep apnea. Previous studies suggested that decrease in the airway space from extraction orthodontic treatment might contribute to the development of OSA. The amount of change in the airway space following orthodontic treatment involving extraction of 4 premolars can increase the risk. So we go to the very bottom, conclusions. The absence of 4 premolars, 1 in each quadrant, and therefore a presumed indicator of past extraction orthodontic treatment is not supported as a significant cause of OSA. I just don't believe that. I don't believe that. A lot of problems with this study. The major problem is that they assume by missing the 4 premolars you had the orthodontics. So you could be missing 4 premolars, not have everything pushed back, not get sleep apnea, and then they would say orthodontics wouldn't cause that, but you never had the orthodontics. Also, they didn't look at patients. They just looked at records. I find this article to be a very weak argument against extraction orthodontics, leading to an increase of obstructive sleep apnea. We just have to use common sense. If humans used to have a wide jaw, all 32 teeth, and now we have 28, sometimes 24 teeth, and everything's pushed back, wouldn't that cause problems? And also, if there's treatments to reduce the symptoms of obstructive sleep apnea by moving the mandible forward, by shocking your tongue and moving your tongue forward, by doing biomimetic oral appliance to expand the maxilla, free the mandible, and that reduces the incidence of obstructive sleep apnea. If there are treatments that reverse extraction orthodontics that reduce the chance of obstructive sleep apnea, if there's surgery that does that, wouldn't that logically correlate to extraction and retraction orthodontics increasing the risk of obstructive sleep apnea? If these other articles I showed you that correlate a retruded mandible to increasing the risk of obstructive sleep apnea, if they correlate the size of the mandible for assessing the risk of obstructive sleep apnea, if the shape of your face can increase the risk of obstructive sleep apnea, and extraction orthodontics puts you in that category of the type of face that leads to increased risk of OSA, isn't it logical to assume that extraction orthodontics maybe doesn't cause obstructive sleep apnea, but increases your risk of obstructive sleep apnea? It just doesn't make sense to me that an orthodontist can cite this article after reading it, after kind of parsing out all the logical fallacies and weaknesses in argument, and still say that there's no increased risk between extraction orthodontics and a developing OSA. I'm not saying it causes it, but I'm saying we have to just take a second look at this. And maybe we start to look at the shape of your face, the size of your tongue, the position of both your jaws, and possibly that could be leading to OSA. I'm just saying, it's possible. It's possible. I don't know why orthodontists don't like this, because it's not like an orthodontist can't just change their way of treating people and still make a lot of money. I totally understand. If you mess with a man's income stream, he's going to have a very hard time changing his mind and his beliefs. I get it. If you told me that biomimetic dentistry, which is my bread and butter in my practice, is terrible for your teeth, I'd have to find massive amounts of research to change my opinion on that. But I just feel like there's a better way to do orthodontics. And I have a lot of friends that are orthodontists, and they don't listen to this podcast, but if they do, I think they're good people. I just think they should reconsider pulling wisdom teeth, premolar teeth, and pushing everything back and increasing the risk of sleep apnea. Guys, I really appreciate you listening to this. I'm not sure if I was rambling and going on. I'm taking a year-long course with Felix Liao. I'm getting a certification in airway mouth doctor. I'm not a physician, but that's just the name of the course. And I'm going to further investigate and hone my clinical skills on expanding children and adults to decrease the risk of sleep apnea. Thanks for listening, and I'll talk to you guys soon.